Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet, and the audio function is on, and the volume is turned up. Please be sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Susan King Lanier and Candace Barrier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and MHSU IDD TBI system announcements and updates. Our focus today is child behavioral health investments. There will also be time for questions after the presentation. At this time, I would like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hello, everyone. It is great to be with you today. I'm really excited about our topic for today. I'm going to do some announcements like I always do, and then I'm going to turn things over to Kelly Shishko. She's on our team. You'll get to know her really well. Today's topic is incredibly important because we are going to talk about the provision of mental health services for children with some of the most complex needs. And those are kids who are currently in our residential treatment facilities. So those may be group homes, they might be psychiatric residential treatment facilities. And with some of the money given to our system by the General Assembly, we are working on some much needed investments to improve the quality of care in those settings to make sure children have the best experience possible, the most therapeutic, and they're able to return to their families and to their communities as soon as possible. So a lot of work needed in that space for some time now. So Kelly's going to talk about all of our work. I think also I want to acknowledge that we've got I2I today. So that's Kelly, and I'll let Kelly introduce herself. But Kelly is lovely and amazing, and you will love her. And she's going to talk all about this initiative. And there is no single person I know that has the passion and the experience of working in this space like Kelly. So it'd be great for you all to get to know her if you don't already, and you'll be seeing more of Kelly. The other thing I wanted to acknowledge before I went into system updates is that I know the I2I conference is happening right now, and I will get to see some of you there tomorrow, but I know a lot of folks are there today, so it will definitely affect our participation. But as a reminder, all of these side-by-side webinars are they're videoed and they're recorded, excuse me, and they're posted to the website. But this won't be the first time at all that we're talking about the children's residential reforms initiatives. So you'll see more of those. Don't you worry about that. All right, so let me do a quick couple of updates before I turn things over to Kelly. So on the next slide is just a big happy holidays from all of us here at the Division of Mental Health, Developmental Disabilities, Substance Use Services, Traumatic Brain Injury, and Problem Gambling. So it's been a wonderful year. We missed, I don't know if you noticed, but we missed the anniversary of Side by Side. Our first Side by Side was in September of 2023. So this is our, if I count correctly, this is our 16th Side by Side. And so I'm grateful that you all, many of you have been with us from the beginning, and I'm grateful every month that new folks are added to our meeting participants. So I want to wish you all a happy holidays from us. I know that holidays can be a joyous, relaxing, wonderful time to give thanks for the people and things in our lives that we are grateful for. I'm grateful for this opportunity to work with you all. I'm grateful to work here at the division. I'm grateful for the great work that we've done and the great work that is coming. I know sometimes holidays are hard for people too, so I want to acknowledge that. There's no right or wrong way to feel in the holiday. There's no right or wrong way to experience the holidays. But regardless, happy holidays to you, no matter how you spend it or how you feel right now. And thank you for spending this moment with us. Next slide, please. So a couple of quick updates. So just wanted to remind folks that our Hope for NC initiative is going strong. Hope for NC is a specific disaster response program for our loved ones, our friends, our colleagues, community members in Western North Carolina impacted by Hurricane Helene. We launched several months ago, we launched the Hope for NC call line. We've had a lot of calls so far. We've had over 1,000 calls. I think the count I saw today was about 3,400 calls so far to the Hope for NC line. And we've been able to support folks through that line with emotional support, referrals for services. And that's community members, that's first responders, that's counselors. But the line is there for anyone who needs supports. In addition to the line, we have begun recruiting community crisis and training community crisis counselors to be on the ground supporting folks. Our first group of crisis counselors were actually in the community the week of Thanksgiving. So they are literally out at events, they're out at food distribution centers, they've gone to community events, they've gone to Thanksgiving, meal feedings, dinners, community dinners. They've gone just for welfare and wellness checks, but their purpose is to go and make sure that they are talking with folks, letting them know about mental health supports in the community, where they can get help. They can provide brief crisis counseling and interventions and information education. They give out these wonderful pamphlets that talk about how people might be feeling in the aftermath of Helene. And those pamphlets, I know it seems like a small thing, but it's not. It's rather a big deal because a lot of times people aren't ready for help for a while, but they've got a pamphlet now. They've got a one pager that tells them about it when they're ready or if they ever need services or a loved one. It's a pamphlet they can give to a friend or neighbor. So these folks really are, these crisis counselors are, they can provide that brief crisis counseling and referral, but they're really also there just to be a presence and to get the word out. So the first cohort of crisis counselors were in the West the first week of the week of Thanksgiving, excuse me. We'll have another cohort trained and out in the field soon. We'll have over 100 crisis counselors by early in the new year, and we're committed to being there for the long haul. Now, this is in addition to all the other incredible things that folks like VIA and partners and community agencies are doing to help. But this is an extra presence to be available in all kinds of community spaces to let folks know that resources are available and to provide short-term brief crisis counseling as needed. There's, again, advertising our Hope for NC website. There's flyers, there's logos, there's Zoom backgrounds if you want to use those. So please do. Next slide, please. I want to remind folks about some things. We just had a video, I think, on ABC 11, just to talk about our partnership with Some Things. Remember what Some Things is. You can go to somethings.com/North Carolina. I think I got that right. This is free peer counseling for teens. So we wanted to make sure that in the aftermath of Helene, but just in general, this is a statewide resource, that if teens need an ongoing source of emotional support, virtually via text or chat or video call, we wanted them to have this program, which is a peer mentor program. And know that they have the ability to escalate and refer if individuals, the young people they're working with, need higher levels of service. But we've had a lot of interest. Hundreds of teens across the state have called. Many have engaged, and we're very excited about the potential of this program. And again, just like any other virtual support, it's a supplement. It's an additional support. And we want to make sure everyone has all the supports that they need. There's no right or wrong way to get support. So we want to make sure that we have this offering for teens as well. So just as a reminder, thank you to Some Things, and also to thank you to Alliance, who brought Some Things to North Carolina. And through our partnership, we were able to expand it statewide. Next slide, please. We had a big hot topic announcement. This is really cool. Remember, I mentioned that we oversee the problem gambling program here in North Carolina. morethanagame.org. Please go to morethanagame.org. So we manage this program. There are tons of resources for problem gambling in the state. You may not realize that. There's the gambling hotline. Friends, family can call that. People who think they have a gambling issue or have questions can call that. And this new initiative that we funded in partnership with ECUs is very exciting. ECU has launched the Gambling Research and Policy Initiative. We had an opening ceremony or celebration ceremony a few weeks ago. Why is this important? This is a national and international center to try to research and understand the impacts of gambling, period, on folks. So it's everything from the reasons that people might gamble, the factors that may go into someone developing a problem, really looking at policies and programs that help people to gamble and manage their gambling responsibly. And it absolutely tries to focus on groups who perhaps are at higher risk for developing gambling problems. So it's very exciting, incredible, important research, especially in light of sports betting being legalized here in North Carolina. But again, it's about learning and understanding, right? It's not about judging or blaming. It's helping us to understand the dynamics here in our state and to create effective policy and programs to address everything from prevention to treatment here in North Carolina. It just helps us get better at our job, and they're very excited about this. Next slide. Something else we want to celebrate is a theme you're going to see here is access. Last month, I think we did an overview of our strategic plan. And one of the priorities here for us at the division is access. We focused a lot last year on crisis, and we'll continue to focus on improving the crisis system. This year, we're going to focus heavily on access and quality. You'll hear us to talk a lot more about quality of care. Kelly's going to talk about that quite a bit when she talks about the residential service improvements. Part of access is making sure we're getting in many different spaces and places, talking about mental health, making sure mental health and substance use resources are available. And we have a really interesting new partnership that we've developed over the past 4 or 5 months. It's actually with the Triangle Business Journal. We partnered with them and the Governor's Institute to actually produce an issue of the Triangle Business Journal dedicated solely to mental health in the workplace. Very exciting. We did several podcasts. This is the point of the journal was to help business owners understand mental health and substance use needs of their workers, of themselves. It was practical tools for what to do and how to develop programs and benefits and make your workplace a safe space to address mental health, a safe space to focus on recovery. So it's very exciting. And this is really important. We all work in workspaces. I work in a workspace. And it's really important that we're trying to, as far as we can, address the mental health and substance use needs of all North Carolinians. And addressing mental health and recovery in the business space is really exciting for us. So we published this article, this whole journal, and there'll be another one actually coming out in the spring. So we're really excited about this. And we have some burgeoning work in this space around creating and certifying recovery and mental health friendly workplaces. It's a brave new world. And when people are looking for jobs, they should look for places that support their mental well-being and their recovery. And that's exciting. We want to be part of the development of a culture like that here in North Carolina. Next slide. Speaking of access, as a reminder, our mental health block grants this year, we were super focused on access, peers, and caregivers. Access in all kinds of different places and spaces that was culturally appropriate. We awarded those, and I'm going to tell you about them in a moment. You know how I feel about peers. At I2I tomorrow, we're talking all about peers. Peers are so important. Peers are so important to help people with their wellness and recovery. We've got a lot of peer centers and recovery community centers in North Carolina, and we need more. So we wanted to fund more peer centers. And lastly, we appreciate very much that there are lots of family and caregiver support entities, community-based agencies that don't have consistent sources of fundings, but they help us. They help families. They help people manage recovery resilience in the community. And families need that kind of support for education, for their own mental well-being. And we need to make sure that we're lifting up those family and caregiver support agencies. On the next slide, the next 2 slides actually, but we'll do one at a time. Here's all of our grantees this year. We got so many wonderful applicants. We have state and regional programs. This page talks about all the community agencies we funded that we think expand access. And this is everything from services for older adults to services in the Latina community to services in the AAPI, so Asian American Pacific Islander community. There are programs here for LGBTQIA+ organizations. I mentioned older adults, faith-based organizations. So there's a lot. Because again, we're trying to make sure that we are available and accessible in all spaces, and that those spaces are equipped to be able to meet the needs, the mental health needs of folks. Doesn't mean we need counselors all over the place. I mean, sure, wouldn't that be great? But the idea is making sure that these organizations and spaces where people do go and they do trust and they will listen and they will talk, those places are equipped with enough programming and supports to be able to help people when they come there for help. So these are all kinds of unique and wonderful programs, all kinds of unique and wonderful. So we're very excited about these. And it was such a success this year. We will be offering these grants again next year. Again, our job is to make sure that we're promoting as much, culturally appropriate access in our communities as we can. So this is the access grants. The next, the next slide. These are our peer respite and recovery hubs and our family and caregiver support program. So we were able to fund the expansion and some new peer respite and recovery hubs in North Carolina. So 3 more of those, and then 4 family and caregiver support programs. Again, another space where we got so many wonderful applications. A lot of people wrote us and said, man, we thought our application was good. So did we. Trust me, so did we. It was very hard. We had to use a very specific rating system to want to be fair. We want to be absolutely fair, and we were. And to all the people reaching out, we thank you for reaching out. We thank you for applying, and know that we will publish these again. And years go fast, right? Year cycles go fast. So look probably in the spring or the April for a new set of grants coming out, and we will advertise this. So we're excited about the good that these can do. All right, next slide. Excuse me. I'm nearing the end before I turn things over to Kelly, but another few celebrations I want to highlight before I turn this over to Kelly. I want to celebrate peers for a moment. Hopefully folks are aware that we have our new Certified Peer Support Specialist website. So it's got tools for peers about curriculum and training and scholarships. It's got information for providers and community members. It's a website to try to help just to have a single source where if you're interested in being a certified peer specialist in North Carolina, you can go right there. You can find out how to become one, what the requirements are, how you can get the standardized training. If you're a provider, you can go in there to understand how you can employ a peer, where they might be, the type of services they can provide, how Medicaid will pay for a peer, for example. And there are peer-to-peer resources on there. So peers helping peers. So it's a really cool website. There's a lot of features. It's one of those websites where we will continue to enhance and grow it. We also have given out 45 peer scholarships today. Remember what the peer scholarships are. These are scholarships so folks can get their certified peer support specialist certification. So we're super excited, 45 already. And we have seen an uptick as well in the number of certified peers actually being employed as a peer in the field. Remember, that's the ultimate outcome. Consistent, easy, good training, peer-to-peer support, and then more people employed as peers in our workforce, because we think that is important. We think it's a good evidence-based model of care, and we need more peers in our workforce. Direct support professionals, on the other hand, folks have been waiting. We released our direct support professional recruitment and retention grants for both provider agencies and employer of record. We got over 300 applications. It's extraordinary. We're planning on giving out to, I would say, $7-ish to $8-ish million in grants. That's about how much we have earmarked for it. It's not going to cover 300 applications, I'm afraid. But we're going to learn a lot from the applications that rise to the top. We're going to learn a lot about what is actually helpful for recruitment and retention. But we will also look for other ways, if there are other promising applicants who didn't make the funding cut, to see if we can fund those. We intend to learn from those. And the end goal, of course, the end goal is that we reduce turnover in staff, and we assure that people have more consistent, well-trained direct support professionals that stay with them. and that direct support professionals get rewarded for retention, and that can be in the form of a bonus, it can be in the form of benefits, it can be in the form of a raise. So these are the kind of things we're looking at, things that would entice people to join the field, but also to stay in the field. And at the end of the day, that equals more people having consistent direct support workers and being able to meet and do their person-centered goals in their home and community in whatever way they see fit. That's the ultimate outcome. All right, next slide.
Okay,
This is really exciting. I think what's coming next. Oh, Jay,
before
is
we
that
get to
you?
the next slide, there's Ginger mentioned in the chat that the DSP grant closes on 12/16.
Oh, wow. Thank you for that, Jay.
The
Is that the EOR, Ginger? Yeah, we released that in 2 stages,
Specific.
the ESP and the EOR. Thank you for that. So I'm sorry, I probably raised a lot of alarm. My apologies. I forgot it was 2 grants. So the DSP for providers closed and the EOR is still open. Okay, thank you for that, Jay, and thank you for that, Ginger. So sorry, I didn't mean to alarm anyone. All right, the next slide I think is really, 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 really exciting. I remember what it is. Oh, I am excited about this, but that's not the slide I thought it was. Remember, we also have an RFA out for justice involved populations. This is exciting too. I just thought it was about the innovations dashboard. So that must be the next slide. Remember our justice RFA. This is part of our funding from the General Assembly. We've already funded some projects to help people avoid being incarcerated, to divert some programs like capacity restoration for people who are incarcerated. We fund programs for people to do reentry. These funds were very specific for more diversion programs. So again, can we help people be diverted away from incarceration and go into a treatment program? So it's for that, but it's also for things like housing, which really helps with diversion and reentry, and also employment services. So we've received a variety of applications for both diversion programs, but also housing, transitional housing for folks who are involved in the justice system, and employment programs. So very exciting. We're looking through this, of course, as fast as we can, and we're hoping early in the year to announce the folks that we're able to issue grants to. Okay, next slide. After all that build up, here it is. I'm just excited about this, and it's tomorrow, and we've gotten a lot of wonderful comments and excitement about this. Ginger and Tina and their teams and Sydney have been working on this for some time now. It's our Innovations Waiver Waitlist Dashboard. There is waitlist information publicly available. I hope folks are very aware of this. But this is a waitlist dashboard that we've worked on in partnership with the LME MCOs, of course, and with Medicaid. And the dashboard is helping us, really, here's the point. It's transparency, right? That's always a point in and of itself. We want to be as transparent as we can with helping everybody understand who's on the waiting list, right? Secondarily, though, we want to learn. We want to learn from the waiting list. What counties have high waiting lists? Who are on those waiting lists? And we really want to make sure that we're developing the right services and supports to meet the needs of people on the waiting list. Remember, a waiver slot is not the only thing that can help folks on the waiting list. So we're tracking things like percentage of people on the waiting list who are actually getting services. And Ginger and Tina and our IDD TBI Olmsted team is working hard with the LME MCOs on things like evaluation and outreach to waiting list members to try to get them into services. So there's a lot happening in that space. But for us, the big step one is just transparency, showing you who's on the waiting list from a statewide perspective and from each LME. So we're very excited about this. And tomorrow, on the next slide, tomorrow there's actually a webinar to actually walk you through the dashboard. This is V1 of the dashboard. I know there's a lot more information we want to know from the waiting list, but this is wonderful. We want to teach you, make sure how you know how to operate it, right? And we will all begin to gather some insights from the list and respond to them, right? We want to respond to them and make sure that we're meeting the needs of people. So please join us for that webinar where we walk you through. And I'm sure it will be recorded like everything else. We'll post it because, again, I know a lot of folks are at I2I tomorrow. Next slide, please. And now, without further ado, it's been a busy month. A lot of things have been happening. And I was glad to share those celebrations and announcements with you. But now for the main event, I'm going to turn things over to Kelly Shusko.
Thank you so much, Director Crosby. Hello, everyone. It's a pleasure to spend some time with you today. I'm Kelly Shusko. I'm a program consultant here at DMHDD SUS, and I have the honor of leading our investments in child behavioral health. We're going to spend a few minutes kind of grounding in these investments, talk a little bit about how we've assessed our residential treatment services here in North Carolina, some early investment work that we've already committed to, as well as our direction forward. Jay, you want to take us to the next slide? So month over month throughout this calendar year, we have brought to you all information about this historic investment in behavioral health services made by our legislature here in North Carolina. One element of that investment is targeting child behavioral health. And you'll see that highlighted in yellow here on this slide. It's a total of $80 million that we as a state are cross-divisionally investing through not only DMH DDSUS, but also our partners at DCFW, DSS, DHB, and DHSR. Next slide, Jay. Collectively, we've identified 6 outcomes that this $80 million will help us to achieve. The first of those is fewer emergency department visits for children and youth for behavioral health needs. The second are fewer children boarding in our DSS offices because they cannot find an appropriate placement. The third is to have fewer children boarding in emergency departments. So less children coming into the ED, but then also less children who are staying there unnecessarily because they're unable to access the service and support that they need. Fourth, we want to have fewer readmissions to out-of-home placements. So when our children do require services outside of their family home and need more intense treatment, we want that treatment to be successful and then be able to resume being in their community with success. Fifth, we hope those lengths of stay in out-of-home placements are shorter than what we're seeing currently, and that more children in foster care with behavioral health needs can continue to live in a home setting as opposed to a facility treatment center. Next slide. So this is a breakdown of that $80 million investment. Where the star is, that's where we're going to be focusing today. So DMH DDSUS is targeting our residential treatment services. Those are levels 2, 3, 4, and our psychiatric residential treatment facilities. So these are all facility-based programs. With our funds, we are focused on increasing the quality and management of residential levels of care, as well as to build specialty care capacity. And that's really unique. That is not just to add beds to our system. We're really striving to understand the complex needs of our children and youth, as well as the support needs of their families, and ensuring that we have treatment programs that are specially trained and equipped to meet those needs. When our children have those needs, and in a way that's very effective, family-oriented, and transitional. Next slide. This is just a nice visual as I talked about the fact that this is systemic. We are sharing this investment to help children and youth all across their treatment journey. So you'll see in the top left quadrant, the total investments from the 80 million that will go towards ensuring the children stay in their homes. This is advances in community-based services with increased evidence-based practices, working with our school systems, supporting our caregivers. These are all with the intention of reducing the opportunity and the need for children to leave their homes. But if their home does become destabilized, we move over to the top right quadrant. And this is where we are looking for emergency placements that can be short-term and crisis stabilization programs, again, so that services can be put in place and children can return home. Sometimes needs might be so complex and they remain elevated and additional support is required. Um, this is where, as a statewide system, we're looking to increase the number of family type therapeutic placements, advancing professional foster parenting with our partners at DSS. And then here at DMH DDSUS, this is where our work to enhance and improve our residential treatment settings lie. But the goal is for our children to come to our programs and then continue around this circle to return to the community again with those appropriate community-based supports. So we are part of this circular system. Next slide. All right, so I want to take a few minutes. We're going to share our vision for where we would like to go with our residential treatment programs. But before we go forward, we always have to stop and really look at where are we today. So I'm going to share a few slides to just kind of orient us to our system. And then we'll talk about some of the opportunities we've identified and some goals for the future. Next slide, Jay. So we began this work in the spring. So I'm going to share our baseline numbers. Now, our numbers of facilities change frequently. We have new providers that join. We have providers who change their capacity. But this gives you a glimpse of these 4 levels. So when we think about residential treatment facilities, we have 14% of our beds are level 2 group homes. More than 60% are level 3 group homes. We have only 5% that are a level 4 program, that's a secure program. And then we have 20% of our beds system-wide that are in psychiatric residential treatment facilities. Next slide. This is a little bit of a different way to look at the reach of our system. When we look at the total number of beds, which was just over 1,200, you can see that by bed, they're nearly equally distributed across our tailored plan geographical regions, although they vary significantly by levels of care. We did note as we were looking at capacity and access to these services that 48 of out of our 100 North Carolina counties have no child or youth treatment facility at all. Now, what creates a challenge with that is if we're trying to keep children connected to their communities, when there's not one close by, then they have to go to other areas of the state to receive the care they need. And we know that is not ideal. Across the remaining 52 counties that do have facilities, there is, as I said, there's nearly an equal number of beds in total across the tailored plans. And the good news is that most of our residential providers do contract with all of our plans to provide service. So children are able to move across the state geographically to receive the care that they require. Also to note, that's not on this slide, an area of concern for us is that about 35% of our youth who require PRTF services are served out of North Carolina. So we obviously know that there is an additional need for acute complex needs and services. Next slide. We took some time to think about utilization. So this is just an example. Again, we're talking about 4 levels of care, but for the sake of time, wanted to highlight the utilization of our psychiatric residential treatment facilities. You can see here that we're actually seeing a decrease in utilization year over year from 2023 to 2024, but still a very high number of youth, nearly 800 youth in the count in 2024, in fiscal year 2024, excuse me, utilize this service. With approximately 243 youth in care on any given day. Our average age for this service typically is our older adolescents, and we've actually seen that age increase from fiscal year 23 to fiscal year 24. So we're now serving on average around 15 years old. And the average length of stay is also declining, but still very extended in this level of care. So we're seeing approximately 7.5 months in service. We are serving more females at this level than males, and that's been consistent year over year. And we are seeing a slight reduction in readmission rates at the 30-day mark. These are all really critical data points for us as we look to understand a child and family's experience in this level of care. Next slide. So, as we looked at data and we looked at capacity, we worked with a team to really complete a comprehensive assessment. We wanted to understand how are services being delivered, where are the challenges, what is working well, and where are our opportunities to really make a positive impact. So we spent about 4 months engaging our providers in focus groups. We engaged them in a survey to really understand the difference between license capacity and operational capacity, as well as factors that drive referral and admission decisions. We visited our PRTFs and have plans to visit our other levels of care in the coming months. We engaged in a very comprehensive literature review to understand best practices. Nationally, we looked at other states and how the residential service array is designed and delivered. And we presented at 2 of our child behavioral health advisory committees to gain input from our stakeholders on direction for this work. Next slide, please. So through that process, we identified 3 really key challenges that we want to commit to resolving over the next year or years. The first is we've seen an over-reliance on residential treatment settings for children in foster care, using our residential facilities to meet the physical placement needs of children and not just the clinical treatment needs. We definitely saw a lack of specialty treatment options for our youth with complex needs. One example that has come up very frequently are youth who have co-occurring behavioral health diagnoses and IDD, specifically those who are on the autism spectrum of diagnoses. And we also saw what we determined to be an insufficient use of trauma-informed and evidence-based practices by our residential treatment providers. It was not at all absent, but we really would like to see more consistent delivery of this approach. So knowing that those were 3 key challenges, we made some driving statements about where we think our residential system is currently. We know that children have prolonged lengths of stay. Remember, the PRTF example was over 7 months on average. And I think that's driven in part by ineffective discharge planning. And children, we're seeing a significant pattern of young people discharging from one treatment setting to another instead of returning home. And if you remember at the beginning of our presentation, one of our overarching goals as a state is to serve children in their communities with their families whenever possible. We know that our children with complex co-occurring needs are more likely to be sent out of state, far from their communities, their home communities. And we heard from a lot of our providers that there is a significant need for ongoing training and support related to de-escalation and alternatives to restrictive intervention. This last one is highly complicated by a high rate of turnover and workforce shortages. So how do we support new hires in developing their skills and expertise to engage with our children and their families during the course of treatment? All right, so now that we've had all these insights gathered, we've crafted a vision for residential treatment here in North Carolina. Here at DMH DDSUS, we are committed to implementing high quality, evidence based care in our residential treatment programs that is trauma informed, that is time limited, that's effective, all while prioritizing and valuing the sustained connection to the child's home and community. With these investments in child behavioral health, we have outlined 4 objectives to help us achieve this vision. The first is to enhance the environments of care in our treatment settings to create safe, trauma-informed treatment programs. This ensures that the care our children receive is safe and is trauma-informed. The second objective is to improve the quality of care delivered within evidence-informed residential treatment settings, ensuring that care is time-limited and that care is truly therapeutic. Third, we strive to increase access so that our children and families have the right service at the right time in the right location. It's care that is intentional and care that is connected to their support systems, connected to their community. And lastly, it is our goal to develop specialized capacity so that we can meet the needs of our youth with complex co-occurring needs, ensuring that care is clinically effective and it truly is specialized. So when children have to leave their homes, it's for expert care and intervention. Next slide, please. So the first objective was environment of care. And this is really kind of the foundation of all of the work we're doing. So if you go to the next slide, we believe that we have to have the right environments in order to be delivering trauma-informed care and effective clinical intervention. So we have some guiding principles here regarding the environment of care and why it was important for us to begin here as we embark on these initiatives. We believe that all of our youth and family should be served in an environment that is well maintained, comfortable, and as home-like as possible. We believe that when youth are in a well-maintained setting, that communicates to them that they are valuable and cared for well. We want every environment that our children and family come to be physically and emotionally safe, and that it promotes the whole person health and well-being within that program. We believe that all of our therapeutic residential settings must provide opportunities for exercise, recreation, social interaction, healthy food, education, and family engagement. And that our youth in residential settings have the opportunities to learn, practice, and utilize self-regulation strategies and coping skills. They need to have the space to do that so they're comfortable and can master these skills so they can use them back in the community. Next slide. Because of this importance, we engaged in a proposal process in the spring with our existing residential treatment providers to submit projects to improve their physical environment. And so we have selected and funded projects that provide new furniture, provide facility repairs, enhance security and fencing in our facilities, to create sensory spaces, and to enhance recreation and outdoor spaces. Next slide. So our first investment went out the door this fall. We have funded 26 environment of care projects across 19 providers in 12 unique counties. This touches programs at all 4 of the service levels we've talked about today. And in addition, we've also provided reserve funding for 7 PRTFs, that's all of the PRTFs in our system, at a per bed investment of just under $4,700. We know that if we can create safe spaces, then our children are more engaged in care. And so this investment on any given day positively impacts 414 youth and helps their settings be more conducive to growth and healing. Next slide. But that is just the beginning. We have so much opportunity here to partner with our providers, our plans, and our youth and our families. So, where shall we go next? Next slide. We have mapped out over 2 years some significant categories where we are focusing our work. You'll see this is color coded according to our 4 objectives we talked about earlier in the presentation. They relate to environment of care in purple, quality of care in green, access to care in blue, and specialized care in yellow. So in fiscal year 2025, which is where we are now, we've started with environment of care, which we just shared about. We are actively engaging in the residential services cost and clinical effectiveness analysis. We are designing a safety initiative. We'll be working with our providers to reduce critical incidents and restrictive interventions. We are also designing specialty care pilots with 2 priority populations. Those are youth with problem sexual behaviors and youth who have both behavioral health and IDD diagnosis, specifically autism spectrum diagnoses. These are 2 populations that through our engagement with providers and our plans were identified as very difficult to serve, but also a high need for service. And very exciting, we're looking at bringing on our residential providers to BH Scan. This is an electronic registry that will soon have electronic referrals, and we can referral sources can identify where beds are, what the specialty is, and have very intentional referrals for service. That will carry us into the next fiscal year, where we'll also be reviewing our current rules and regulations for these services, as well as our clinical policy review. Next slide. It continues. So then as we go further into fiscal year 26, we'll be working on trauma-informed treatment models and evidence-based practices and how the state can support our providers with their implementation and sustainability. We'll be looking for innovation and how we can optimize transitions for our youth and families as youth enter into residential programs and how they exit back to their communities with the right services and supports. We'll also be looking for innovation around how we continue to strengthen their support systems throughout their course of treatment. And then we'll return to additional specialty care pilots, looking at co-occurring behavioral health and substance use, as well as youth who are involved in juvenile justice and have behavioral health needs. And then another population that our providers have expressed significant interest in serving and developing unique programs are for our youth who identify as LGBTQIA+. This will all culminate in an opportunity for us to look at how do we redesign the system in its entirety to best serve our youth and their families. And we'll be capping it off in fiscal year 27 with a quality assurance and performance improvement model so that we can really evaluate the quality and the impact of these services and continue to invest in high quality, safe, and effective programs. Next slide. So there's a lot of work to be done, and we cannot do it alone. So I'm happy to be able to introduce this work to you all here this afternoon. Shortly, as after the start of the next calendar year, we'll be looking to develop a youth and family council to come alongside us with this work, as well as a residential provider work group. And we do plan to host some forums with our tailored plans and the CFSP as we move forward with its launch. All right, next up. All right, and now we're to Q&A.
Hey everyone, I'm Adam Barnard. I'll be guiding us through the Q&A today. Um, I think we're going to start with a question that's been asked in the chat here. How is data being collected on what families would find helpful when going through residential services and then coming out again?
It's a great question. We are working with some of our family advisory groups, as well as some advocacy organizations to develop a youth and family engagement strategy. So we are looking to, one, gain some firsthand accounts and information from youth and families themselves as far as their experiences in the system. And then are looking at a systemic way to capture perceptions of care, experiences in care, and satisfaction of care across all providers as we move forward in this work. So much more to come on that.
Can I say though, how much I appreciate that question and how much that is a priority for us?
Absolutely.
Because it just is. I think, Kelly she mentioned this and she mentioned engaging with providers because it's really critical that we're talking with folks in the system and about changes and that we want to build those changes with people. But at the end of the day, this is very much about families who rely on these types of treatment settings, and we don't even know why sometimes, like what they expected that treatment to be, why they thought that was the right treatment for their child. Did they choose that? Did they feel like they had no choice? And for the children who were in residential settings, what was the experience like for them? And knowing and really understanding both from families and from consumers who have been in those residential services, what it was like, what are the strengths that we can build upon, and what are the things that really, really need to change. So I just want to say I appreciate that question because that is the most important thing, the experience of the child or adolescent in the facility, and secondarily, it's the family. So
Yeah.
that is priority, and I know that Kelly has spent a lot of time talking with youth and family serving agencies, and those conversations are sometimes, quite difficult. And we want to engage in those conversations respectfully and at the right pace and time that families are ready. But for kids who are currently in facilities or going through the process of being assessed for a facility, how are we hearing their voice in the system? I think that is absolutely critical. And while children are in facilities, how are we making sure that we are actively listening to them and that they have advocates helping explain to us what their experience is like?
Along some similar lines, as we're hearing from people who have lived experience in these facilities and also community members who have been impacted by it, we've had some questions about how interested parties get in touch to let us know that they're interested in being a part of things like our Youth and Family Council or some of those other groups that you'd mentioned, Kelly Shusko, as you were talking about community input.
Yeah, absolutely. Happy to share out our contact information. But also, I think we have a slide at the end here with our Child Behavioral Health Advisory Council, and I invite anyone to join us there. It does meet monthly. It's a great way to connect with us on an ongoing basis. And from there, we're happy to make additional connections.
That's great. I think we have time for just a couple more questions here. Let's see. I'm sorry, they're starting to pour in, so I'm sorting through all of this. Is there any word on a go live date for the Child and Family Specialty Plan?
Nope.
No word
I think
on
what's really critical, and I'm so glad people asked that because the Child and Family Specialty Plan was like Taylor plans, like folks are kind of worried about what that experience will be like. Rightly so, understandably so. It's certainly not going to be December of 2024 because here we are. I promise you that the department and the Medicaid team are working very swiftly on getting an announcement out about a projected go live date. But I would say, please know that regardless of the Child and Family Specialty Plan starting or whatever, we will be working, this residential redesign will span Medicaid products. It just will. So you could be in a standard plan. Well, no, you can't. You could be in a tailored plan. You could be in Medicaid Direct. You could be in a child and family specialty plan. All those different flavors of Medicaid plans, which are all great. We'll be working with all of them because these facilities serve all children in North Carolina. So we will be working closely with CFSP, Child and Family Specialty Plan.
That makes a lot of sense. I have one clarifying question about the data that we've presented about our youth and PRTF services. Does your data regarding use of PRTF services include those North Carolina youth who were placed in out-of-state PRTFs?
So the slide in today's presentation were our North Carolina PRTFs, but we have been tracking data on our youth who were served outside of North Carolina, looking at all of those same points, as well as what is the specialization of the programs they're going to, the duration of their care there, and the discharge planning on their return. So we're very concerned about that, and it is an area of data that we are looking at with a lot of focus.
I will say, because I don't want us to be giving competing answers, I will say in the chat, I did say we have data. Do we have the depth and breadth of the data that Kelly shared? Absolutely not. But merely through claims data, we can tell you right now what facilities children are in and if they're out of state. And we can tell you on the claim, right, what got paid for, what diagnosis the child has. But and we can tell you their demographics, their age, and their gender, and what county they came from, and if they're involved in DSS or not. That's it. That's the end of the data, but it's not nothing. It's actually a pretty rich data set. But to the level that Kelly has, right, that is a different level of data. But I say that because I want you to know that we are, of course, that's a priority group for us, wanting to understand where all kids are in and out of state, and anything we can know about them now and later.
Thank you all so much for such thorough answers to the questions that we've gotten through the chat. I know that we didn't get through every single question, but I think that we're about bumping at time, and the additional questions would require, I think, some length of response.
I want to, could I say one thing, Adam? Because there's a theme, an understandable theme here about things like kinship care. Can kids just stay with their families? To access for treatment in rural areas. Like I just want to say, like, I think all of those are absolutely things that are part. I think Kelly did a great job of talking about the continuum of how all the divisions are working together, right? So we're working with the Division of Social Services. We need more treatment, foster care, and more kinship care. And our division can lift it up so people know that kinship care is a thing and you can get paid for it. Because yeah, ultimately, if there is a safe, loving family that wants to support a child and take the child in with services, we want that to happen too. Rural areas, yeah, I think one of the things, it's interesting, we're trying to balance having enough group home facilities or treatment or PRTF facilities where people have access, where children have access so they can be close to home. But I think we're being really open to say that doesn't always mean a group home or a residential facility. Maybe that rural area needs more foster families or more wraparound care, because Kelly said this, but I want to emphasize, the answer to a lot of this is not more facilities by any stretch. It's only enough, and ones that have high quality specialized care, but really building up the community continuum, because ideally we want to create a system where we very rarely have children in out of home treatment facilities, very, very rarely. But the reality is, as Kelly showed you the data, hundreds of children are in facilities now. They just are, because it's part of our treatment continuum. Therefore, we need to do everything while we're working with our other divisions to build up community capacity, right? We have to make sure that these kids are getting superlative treatment and care, as Kelly emphasized, when they are in facilities currently. So that's what we're super focused on, but making sure we have the right kind of capacity in rural areas with family. So thank you for those questions. I think they're really important. So I'm going to turn this back over to Dina, but I want to thank Kelly today for all the work. I want to thank the community who's on the Child Advisory Group. I want to thank our sister divisions, DSS, DCFW, Medicaid, DHSR. It takes a village, it takes a whole department. We are one department. And please hear that emphasis of, and I know Kelly showed that to you. Yep, here we are, DMHDDSUS, because it's us working on the highest end of the continuum. But we'd love a situation where we don't need that highest end of the continuum anymore, quite frankly, right? So we're working with our sister divisions to make sure that we're filling out the whole continuum. But this, I know a lot of folks on this call today because this matters to them. Their child has been in a facility, they've been in a facility. There are people like Kelly who've worked in this environment with kids who need the most help sometimes, or families that need the most help. So this one is very near and dear to our hearts. We're delighted to have you with us today. We're delighted to have you join our advisory committee, and good stuff will happen in this space in partnership with y'all. So thank you very much for being with us today. Dina, over to you.
Thank you, Kelly. If we did not get an opportunity to answer your question during the webinar, questions and feedback are always welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our Community Engagement and Training webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, January 6, 2025, from 2 to 3 p.m., and we look forward to seeing you then. This concludes our webinar for today. Thank you for attending.